Hi, so I'm Mohammad Dehabadi, and I'm an ocular plastic surgeon down here in London, and I'm really happy to be having this conversation with you today.
Thank you so much for joining me today and, kind of talking through the process of an eye removal surgery. My name is Shelby, and I'm the founder and creator of EYEHESIVE. But let's get back over to you. So, how long have you been an eye surgeon?
So basically, I've been an eye surgeon in general for about 10 years, and I would say for the last 2 to 3 years, I've been subspecializing in ocular plastics. So that's usually kind of a surgery for the eyelids, the lacrimal system, but also kind of more major surgery around the eye, which is eye removal surgery, which is kind of what we're going to be talking about today.
Amazing. And so that's kind of the journey into, um, how you got here. Maybe what school did you go to, and what does that look like if someone was to want to do this as a profession?
So it's a pretty long road. In the UK, we have about 5 or 6 years of medical school, and I did my medical school at Cambridge University and UCL in London. And then there's a 2 or 3 years of general medical and surgical kind of training as a junior doctor before we choose our specialties. And then there's a 7 year kind of general ophthalmology training, which is when you just do eye surgery and kind of medicine around the eye. And then after that, you usually do fellowships. And that's when you kind of subspecialize in your kind of chosen field. And for me, that would be ocular plastics. So for the past couple of years, I've been really concentrating on ocular plastics. But we're all kind of fully trained ophthalmologists. I still do cataract surgery. So we kind of do general ophthalmology plus the subspecialty of our choice, which is kind of ocular plastics for me.
Amazing. That's so interesting. Yeah, love hearing about things that I never even knew existed before my eye injury or needing my eye removed.
Mm.
How often do you do eye removal surgeries?
So I work in a kind of very large tertiary center in central London. Um, so for our department, I would say we probably do eye removal surgery maybe 2 to 3 times a week as a department, not personally, but as a whole department. But overall, I would say it's one of the rarer surgeries that is done in ophthalmology. As you can imagine, things need to be fairly drastic before an eye really needs to be removed. So it's not the most common thing that we do, of course, but it's fairly common in a big department like mine, for example.
Okay. And just out of curiosity, what is like the main cause, would you say, for eye removal, or main age range? If you have any kind of insight on that.
So in terms of age range, I would say it's unfortunately something that can be done is done for all sorts of ages. Different kind of ages have different common issues that they have. For example, if we're doing eye removal in children, it's usually because of severe cancer. Um, so that's one of the main reasons for eye removal. And then you have the kind of young adults range, such as yourself, for example, where it's more kind of trauma related, or if they've had a chronic eye condition all their life and the eye kind of then becomes a painful eye by this age, then that's the kind of next kind of demographic of patients who then end up having their eyes removed. So the kind of young adults. And then there are kind of then the kind of cancers that come later life. So then there's another peak of eye removal, I guess, later in life when patients get melanomas in their eyes or kind of skin cancers, severe skin cancers that then invade the orbital tissues that need eye removal. So the age range is really varied. And I guess the reasons are also fairly varied.
How many different ways can an eye removal be done?
So broadly speaking, there's only three ways kind of eye removal surgery is done. The most invasive and the kind of rarest form, I suppose, is what we call exenteration, where both the eye, the muscles, basically everything within the bony orbit is removed. And that's only really done for kind of very invasive cancers, which have kind of gone into the eye and the tissue surrounding it. And that's fairly disfiguring surgery. So you kind of can lose your eyelids. It's basically essentially a large hollow, and that's very rarely done. So that's the most drastic way. And then I guess the kind of middle ground way of removing an eye would be what we call enucleation, which is where is probably what most people imagine an eye removal to be, which is the whole kind of eyeball is removed, the muscles are detached, and the ball of the eye is removed, and a kind of a prosthetic ball is put in where the muscles are reattached to that. But again, that's not really commonly done. That's only ever done if you need to kind of exclude cancer. So that's most commonly done in children where they've got retinoblastomas or other cancers. And that's when you kind of want the whole eye intact so that whatever's inside the socket doesn't spread after you removed it. So again, the commonest way that an eye is removed is something called evisceration. And basically what that involves is removing the clear part of the eye, the colored part of the eye, and the contents, but leaving the white shell of the eye. So the kind of the white of the eye, which is quite a tough kind of tissue. We leave that behind so that we can use that to cover the implant that we put into the eye socket. So that's the commonest way. And that way we don't have to detach the muscles or do anything. And the eye has a little bit more movement because the muscles are kind of attached to where they should be still. And that's called an evisceration. And I would say that's probably the commonest by far way that an eye is removed.
And then talking about the post, care, what is that like? So for someone that's, having the evisceration or enucleation, what would the care be?
So in terms of the operation itself, believe it or not, it can actually be done with the patient awake, which most people wouldn't imagine. So for example, if you have a very elderly patient who just cannot go under general anesthetic where they still need their eye removed, we can fairly effectively block, give a kind of very good block around the eye where you feel nothing, and the operation can be done. But most commonly it's done under general anesthetic, especially for the younger patients who just won't want to be going through that sort of thing. So the operation itself takes about an hour. After the operation, the first thing that patients notice is for the first 24, 48 hours, there can be quite a lot of pain and quite a lot of pressure sensation. And that comes from having to put a large implant into the socket so that we kind of give as much volume back to the patient as possible. We try to replace the volume of the eye that's lost with as much volume as possible. But that initially causes a lot of pressure and pain for the patient for the first few days. And that can be, causing nausea. So patients often kind of complain of a lot of pain or nausea if it's not managed. So we usually keep our patients in hospital for the first 24 hours so that they can stay in, get morphine overnight, have antiemetics on board so that they don't feel sick. And only kind of, the next day when they're feeling much better and things have kind of started to settle, do we let them go home. In terms of looking after things, for the first week, I tend to kind of just keep my patients padded so that the big pad that you go home with doesn't come off. And the reason for that is that the surgery causes a lot of swelling. The tissues around the eye can swell quite significantly, and the eyelids can become quite swollen. So for the first week, it's best to have a pressure padding on so that the swelling can be reduced as much as possible. And even after the first week, when we see the patient, we take the we usually like to do the kind of dressing removal ourselves, so the patient is not kind of on their own when they first see what's left behind, as it were. And even then, there'll still be quite a lot of swelling in the first week. And then after that, I would say over the space of 6 weeks, things start to settle down.
Any things that should be looked for of like concern, if it's like swelling too much or bruising too much or leaking or things like that, that you would just...
Yeah, that's a really good question. So generally speaking, after any sort of surgery, we would say things should be getting better day by day. They should never get better and then get worse again. So if you ever notice that your pain is getting worse rather than better, if the swelling is getting worse rather than better, or if there's a lot of kind of gunky discharge from the socket, or the swelling is kind of becoming more red, more swollen, then that's definitely a sign that you should go back to your surgeon so that they can have a look. Because of course, one of the risks with any surgery, especially with surgery where we're putting essentially a foreign body into a cavity, is infection. So you can have an infection where you can get an infection around the implant in the first few weeks, and that definitely needs intervention if that happens. So yeah, if your pain is getting worse, if your swelling is getting worse, or if you have a lot of kind of green colored yellow discharge, then those are things that kind of should alert you to see your surgeon.
Okay, thank you. And is there anything else that you think's really beneficial for someone to know when they're about to have their eye surgery, like either pre, post, during, if someone's walking in, or for a guardian,
so
even someone taking
I
care?
think it's really important to kind of know what you're getting yourself into, especially if you're having this surgery done as an elective kind of, so you're choosing to have it done because you've had a niggly painful eye for some time. So if I have a young patient who's coming to us for surgery, and kind of I ask them what they're doing at the moment, have they got exams coming up, have they got important dates that they want to be available for, I would recommend you need a few weeks off. You at least need good 2 weeks of completely off work. You're not going to want to be concentrating on things if you have. So that's one thing that I would say patients should kind of be aware that for a couple of weeks they're not going to be feeling their best, not just cosmetically but also physically. They might be on painkillers, they might not be happy to kind of go out and about. So that's one thing I would say. And the other thing is that they need to also be mindful that it takes a while, as you've seen, to get your final prosthesis and kind of get your cosmetic kind of outcome that you're wanting. And again, telling patients that from the very beginning, setting their expectation that it will be a few months before they get that final cosmetic shell is very important, because often patients expect to kind of wake up and have the thing already there. And if you haven't kind of counseled your patient through all the weeks and months that's going to take to get there, then they're going to not be very happy.
I really appreciate you coming on today and doing this. And, we'll put this video together and maybe, do some more filming down the line.
No, just keep doing what you're doing. Well done. I think it's a great community, and yeah, anything I can do to help, I'm always happy.